Go ahead and get started now. So welcome back, everyone. This is day 2 of the Law and Policy webinar series. As mentioned yesterday, this is part of a larger dissemination effort to share information related to our recently released abortion care guideline. Before we dive in, just a couple of housekeeping rules. So 1, please note that we have simultaneous translation occurring in Spanish and in French. So please click the globe at the bottom right-hand corner and choose which language you prefer. We also ask all speakers to speak slowly so that the translators can do their best. 2, after the recommendations are presented and the panelists have had an opportunity to join in a discussion with us, we will open up the floor for a Q&A portion. We ask that all questions be posted in the Q&A function, not the chat function. We recognize that throughout the presentation and discussion, you may have burning questions, and so you can go ahead and post those in the Q&A, and we will do our very best to address them all as quickly as we can. And finally, please note that the webinar will be recorded. You'll have access to yesterday's recording as well, and so at the end of today's webinar, I'll highlight once again how you'll be able to access these recordings and the PowerPoint presentations, and you can therefore share that information moving forward. So on that note, let's get started. First, I'd like to do some introductions. Fiona, can I ask you to come on and introduce yourself?
Sure. Hello, everybody. My name is Fiona Delandris, and I'm the Professor of Global Legal Studies at Birmingham Law School in the UK, and I worked with the team on developing the evidence base for the law and policy recommendations.
Great, thank you very much. Next, Laura Gill, please.
Yes, hi, good morning. My name is Laura Hill. I'm an obstetrician and gynecologist in Colombia. I am also an abortion provider, and I am also an activist in Colombia for women's rights. Great, and I am part of the Safe Abortion Committee at FIGO.
Fantastic, thank you. And Godfrey Kingat?
Hello, everyone. My name is Godfrey Kangaude, and I'm a lawyer. I specialize in sexual and reproductive health and rights. I work in Malawi on advocacy to a safe abortion. Currently, I am a postdoctoral fellow with Rhodes University in South Africa. Thank you.
Great. Fiona, I'll have you come back in while I get our slides ready for today.
Yes, thanks, Antonella. So we just wanted to start by framing the webinar a little bit and remembering what our focus is here. So in these webinars, we are focusing on the law and policy recommendations within the abortion care guideline. In other words, on recommendations that relate to the regulatory context in which abortion is provided, managed, or received, and that supports quality abortion care. So we are thinking about and seeking to remember that these are recommendations that relate to that context rather than being rules for what individual providers may or may not do in any particular set of circumstances. In addition, even though we're going to focus today on 3 particular recommendations, we just want to reinforce the fact, as the guideline says, that all of the 7 law and policy recommendations are interconnected and they, relate to each other. I think that will come out in the discussion that we have about them today as well. So the guideline and the recommendations on law and policy within that guideline are focused on seeking to support an enabling environment for quality abortion care, and one part of the enabling environment is respect for human rights, including support of law and policy. So that's the focus that we want to maintain in terms of those recommendations today.
Great, thank you so much. So just as a reminder, yesterday we provided an introduction to the guideline, an explanation of our approach and process, and we reviewed all 7 recommendations. which for the purposes of the guideline and evidence review, we artificially split into distinct interventions. But as Fiona has mentioned, and as we saw multiple times yesterday, these are all connected and quite dependent on one another. So today we will focus on 3 recommendations and invite our panelists to share their experiences working with and on these issues. But I invite you to listen to yesterday's recording, and we're eager to get started today. So before we get into the discussion, I just want to quickly review the 3 recommendations that we'll be discussing today. So these 3 recommendations can be found in the abortion regulation section of the guideline. And so specifically, we're talking about criminalization, grounds-based approaches, and gestational age limits. And as a reminder, as discussed yesterday, unlike other health services, abortion is commonly regulated to varying degrees in the criminal law, in addition to regulation under healthcare law. And so for the guideline, the recommendation is for the full decriminalization of abortion. And by decriminalization, again, we mean removing abortion from all penal or criminal laws, not applying other criminal offenses such as murder or manslaughter to abortion, and ensuring that there are no criminal penalties for any actor involved in the process. So that could include the pregnant person themselves, anyone assisting in the process, whether it is to provide information, performing the abortion, or accompanying the person undergoing the abortion. Decriminalization would ensure that anyone who has experienced pregnancy loss is not suspected of illegal abortion, and it does not make women vulnerable to forced or coerced abortion, because these actions would constitute serious assaults that are covered by other laws. It's important to note that decriminalization is a necessary step for the legalization of abortion, but further legal or regulatory changes will be required to ensure that abortion is available, accessible, and of high quality. Even in settings where abortion is criminalized, national laws in almost all countries permit abortions under prescribed grounds or specific circumstances. And as reviewed yesterday, these circumstances can vary widely by country. And so the recommendation here is against laws and other regulations that restrict abortion by grounds, and recommends that abortion be available on request without justification as to reason. And finally, we know that grounds-based approaches are commonly accompanied by gestational age limits, which restrict when lawful abortion may be accessed by reference to the gestational age of a pregnancy. And these limits can also vary depending on the condition under which abortion is sought, also depending on a whole host of other factors. Thus, the recommendation is against laws and other regulations that prohibit abortion based on gestational age limits. And as mentioned yesterday, this is a regulatory recommendation. This is in line with what Fiona had started us out with today. This is not a recommendation about when abortion should or should not be done, nor are we speaking to issues of viability. Gestational age limits that exist in law or policy are arbitrarily set and are not evidence-based. We know that pregnancy can and is often ended in many settings at various gestations, and they may be relevant to things like which method is sought. And so this is the basis for this recommendation. And just to quickly highlight, here are some of the outcomes we observed in the data as reviewed by Fiona yesterday. And again, detailed information is available in our evidence to decision frameworks. We've provided the links prior and we'll do so again. Okay, over to you, Fiona.
All right, great. Laura, hopefully we can start by talking to you a little bit about your experience working in Colombia of the regulation of abortion through the criminal law. So what kind of impacts of criminalization do you observe in your practice?
Sure, Fiona. During all my training as an OBGYN, abortion was completely banned in Colombia. But that did not stop abortions from happening. Luckily, at that time, misoprostol already existed, but still, I witnessed women with their organs teared apart, like literally, or with severe infections after a long and complicated surgery being interrogated by the police because, according to my professors, it was an ethical duty to denounce them so that abortions would stop. They did never stop, of course, although they were gradually replaced by less unsafe ones. But even so, I saw many women suffer because when they went to the emergency room bleeding and the personnel assumed that it was an induced abortion, some were reported and prosecuted. Criminalization causes stigma and makes doctors more prone to violate their duty of keeping medical secrecy. I also heard stories of women who had to sell their few belongings to pay for a clandestine abortion, or who were even sexually abused during a clandestine abortion. Also, some who were forced to have an abortion at a clandestine site where no one even cared to ask them if it was really their decision or if they were victims of sexual violence. Criminalization creates a window of opportunity for financial abuse, for unsafe abortion, of course, and also for forced abortion, and even for the cover-up of sexual violence. I am sure that no matter what we think of abortion, what our opinion is as providers, we don't want a law that can cause so much harm in our countries. I also got to meet many women who had abortions in a safe and dignified way because they had enough means and information. Criminalization creates inequality because only the most vulnerable ones are criminalized. Later, when I was already practicing as an OBGYN, abortion was partially decriminalized by grounds. Those grounds in Colombia were risk to health or life, rape, and unviable malformations, fetal malformations. For 15 years, I lived the struggle for the implementation of those exceptions. 12-year-old girls who were told that many girls their age had been giving birth without any problems and therefore were not at risk, for example. Rape survivors being questioned about actually having been raped or making it up just to get an abortion. Or women carrying clearly and viable fetal malformations who were required to wait until an accurate genetic diagnosis was done before allowing them to have a termination. Some women and girls were lucky enough to find a doctor who would have the knowledge and the recognition of their mental and social well-being as an important part of their health, and several who still had to resort to clandestine abortion, even though they were clearly entitled to a legal one. Many colleagues also felt disturbed by feeling that they were allowing abortions to happen by certifying that risk to health or life or a fatal malformation, especially if they were conscientious objectors. Some felt that it was unfair that the burden of deciding whether something was a crime or not was on them. They feared being charged with illegal abortion if their arguments were not considered valid in the future. And it was very confusing for them that abortion was both a right and a crime at the same time, but the burden of such confusion was primarily borne by women and girls in the form of barriers to access abortion. The grant system creates inequality, uncertainty, and misinformation among women and girls who need an abortion. It also causes fear, stigma, and work overload for hospitals and doctors that are committed to an accurate interpretation of the grounds with a human rights approach. Grounds also open the door to abusing conscientious objection by allowing biased interpretation of the law hidden behind a personal anti-abortion position. When it comes to gestational age limits, there are also great injustice. It is precisely women who require an abortion at higher gestational ages who are most vulnerable. They are girls who have never had their first menses and who only discover their pregnancy when someone notices their belly. Or they are indigenous women or migrant women who must walk for weeks to reach a city when they can find an abortion provider. They are women in situations of such degree of violence that they are unable to seek help sooner. It is also precisely women who have abortion in more advanced stages who are more likely to die or suffer severe complications from clandestine abortions. Gestational age limits also create an opportunity for those who oppose abortion to abuse their caregiving-patient relationship by delaying abortion requests until the pregnancy exceeds that established limit. When abortion is considered a crime above a certain gestational age, we are criminalizing women who needs us most. We are telling them that at some point, the fetus acquires greater rights than them. That her only option is to get an unsafe abortion, the most unsafe of all, that's advanced gestational age limits abortion, instead of coming to us to get evidence-based care through safe techniques that exist for terminating pregnancy at any given stage. And we are also sending the message to our communities that if someone has a serious complication from an abortion in the second or third trimester, they better do not come for help within the healthcare system, because they will be reported, because it's a crime, and they will be prosecuted. This is what criminalization, whether it is by grounds or gestational age limits or both, looks like in daily practice and to the eyes of the community that we serve. And that is why it should be regulated just as any other healthcare, so that the focus can then be on delivery of quality care and not on evaluating, judging, or validating personal high impact decisions that have a great toll on women's and girls' lives. So Fiona, it will take years to change the penal code in most contexts. So what, if anything, can really be done now, and how can we help with this?
Yeah, thanks, Laura, and thank you for that really rich response, which I think, just before I talk about what could be done now, I think the response that you gave us really, illustrates quite a lot of the evidence that we also saw when we were developing the evidence base for the guideline. So, for example, our evidence showed precisely the kind of phenomena that you mentioned there, including people being interrogated or questioned when they present for post-abortion care, or availing of or having recourse to unsafe abortions because they cannot acquire them within the formal health system. As well as that kind of exposure to interpersonal harm and violence that you mentioned that women often experience. And our evidence also showed, as you there illustrated, that criminalization, as well as grounds and gestational limits, they create significant workload implications for healthcare providers as well. Both bureaucratic, trying to ensure that you fill out all the right forms and do everything you have to do to ensure that you're establishing legality, but also that kind of weight of, I guess, responsibility, or that burden that constitutes trying to determine legality in a particular case by reference to grounds and gestational limits. So I think that's a really valuable set of observations. It also, I think, very clearly illustrates the ways in which criminalization, grounds, and gestational limits are all connected. Because ultimately, with very few exceptions, where abortion is a crime, there are some exceptions to that. In other words, there are still some circumstances in which abortion is lawful, and those circumstances are usually identified by reference to a ground or a gestational age limit or both. So in some ways, the criminalization of abortion kind of creates a necessity in the regulation to have grounds or to have gestational limits, because you have to have some kind of line between what is criminal and what is not criminal. And the last thing, just before I answer your question, to me that struck me from what you said was around the interpretation of grounds. So the guideline recommends against grounds-based approaches, for abortion, but there is also a remark or a set of text that acknowledges that in lots of jurisdictions, grounds do exist. And where those grounds exist, they can be more or less conducive to quality abortion care, depending on how they're interpreted. And there you mentioned taking into account a very holistic interpretation of health, which in essence would be in line with the WHO interpretation of health. So that's somewhere between having no grounds because you have a complete ban and having no grounds because you have abortion on request. There are different ways of having a grounds-based law, that are more or less restrictive, and a lot of work can take place in that space as well, in the process of moving towards an on-request system, if that's what's going to happen. So sorry for the diversion, but I just thought that your answer was so rich, it was useful to pull that out. So then you asked me about, this process of changing the penal code and what can happen, let's say, between the point of criminalization and full decriminalization as the guideline recommends. And I think that really is such an important question because, as I said, when the starting point is that abortion is a crime, you have all these regulatory imperatives, to have grounds or to have some other kind of system. But the question is then what can happen in between time? And what's interesting is, first of all, that there are things governments can do even before they manage to change the law to minimize the impact of the criminalization of abortion. So, for example, a government could say that they are suspending all prosecutions for abortion. So it's perfectly permissible, perfectly fine to have a moratorium or to suspend criminalization. And that would mean you stop all investigations, you stop all prosecutions, and you no longer start new prosecutions or new investigations while you're in the process of considering your law reform. And that's not unusual in other kinds of areas of complex policy regulation, that you would suspend the application of a criminal law at that time. Now, in order to make that, let's say, really meaningful, of course, it would be important for the change, for the suspension of the law to be clearly communicated. So clearly communicated to providers so that they know they are not required or expected to report anybody that they consider may have had an abortion when they present for post-abortion care, for example. And also, of course, to communicate clearly to pregnant people themselves that they will not be reported, they will not be investigated, there will not be any prosecutions. That is just for an example of where a place where that happened. That is what happened in Northern Ireland, where abortion was a very serious offence, and the UN Committee on the Convention of the Elimination of All Forms of Discrimination Against Women recommended that the government immediately stop applying these criminal laws to abortion, and a moratorium was introduced in the first instance. Then abortion was, the overall criminalization was removed, and then a new law was introduced that said it would never be a crime for a woman and outlined when abortion would be legal. So it's still criminalized for providers outside of the permitted exceptions, but they decriminalized it for women, and they did this moratorium at the start. But Northern Ireland also illustrates something Antonella said when she was introducing this about how decriminalization alone is not sufficient, because now in Northern Ireland you have no criminal offence for women, you have a clear law about when abortion is permitted, but you don't actually have very many services being provided because the services haven't been set up yet. So there's there are these multiple steps, and of course law and policy is only one of them.
Fiona,
yeah.
I just come in for 1 second because we have a question that's also about whether or not the reverse is true. And I think you've just touched on it in talking about the fact that some actors might be decriminalized while others are not. And so the question is really about whether or not there are contexts where abortion is legal in some cases, but not criminalized. And we know that there are examples of that. So I don't know if you just want to speak to that very quickly.
Yeah, so just to, I think I understand the question, but if I don't, please follow up with another question in case I get you, in case I get you wrong. But yeah, there are circumstances in which, well, nobody is criminalized. They're rare jurisdictions, and you just treat abortion like any other part of healthcare. So its provision is determined by clinical appropriateness, patient value and preference, and so on and so forth, as anything else would be. And then in some settings, it's never a crime for the woman to have an abortion, but it would be a crime for a health worker to provide an abortion unless they complied exactly with the law. And that law is usually based around either grounds or age limits or both, then with some additional requirements, sometimes like mandatory waiting periods or whatever. So the idea of abortion being, you said there, legal in some cases, but not criminalized, it's kind of complex, but I hope that answer gives you an impression of it. Basically, if there are any circumstances in which abortion could be a crime, then you have a system that is based on criminalization, because the system is designed to identify the cases in which it's not a crime, so that providers know what they can do and when they can do it. And I'll again just emphasize something that Antonella already said in relation to that, and that is that the concern that's sometimes expressed that if abortion is never a crime, women would be vulnerable to exploitation or coercion. That's not something. So the risk of, let's say, coerced abortion does not require abortion to be a crime to address it legally, because there will be lots of other offences available, like assault. So like any non-consensual trespass on your body is an assault. And any doctors here will know you can't do anything. You can't have an intervention without the informed consent of the person in respect of whom the intervention would take place. So all those normal rules, of everyday life and everyday health practice would continue to operate and would simply apply to abortion like they do to everything else. So sorry, Laura, that's a very long answer to your question, but I hope it's helpful in some way to try to identify something that could be done as an interim step towards decriminalization in the law.
Great, thanks.
So another question for you, Laura, from me is the recommendation that the guideline makes against a grounds-based approach and the recommendation for abortion on request. Is that something, and without gestation limits, is that something as a provider that you have concerns about, or how do you think that would actually work? What would that mean in practice? What would be the benefits of that in practice?
Well, I can give you a very close glance of what I'm living right now, because in Colombia, at the beginning of this year, the exceptions for legal abortion were eliminated up to the 24th week, meaning that abortion may be requested based on the pregnant person's own reasons up to that gestational age and then after the 24th week for the exceptions that we had before. I am part of Global Doctors for Choice, as I said in my presentation, and we in turn are part of the movement Causa Justa, which is the fair cause, the just cause. And along with more than other 100 organizations, we built strong evidence and human rights-based arguments and submitted them to the Constitutional Court, demonstrating why maintaining abortion as a crime was unconstitutional. As a result, the court ruled that indeed that decision of having abortion as such, having abortion as a crime, and having an abortion was such a personal and intimate matter that questioning it and requiring a validation from someone else was against most fundamental rights. So I can speak very close of what is going on right now with partial decriminalization, because we still have a gestational age limit of 24 weeks, which is not what we asked for to the Constitutional Court, but we have something very similar to what we had, and it's no grounds before 24 weeks. Since then, many women have been able to access safe abortion and free legal abortion services because they are covered by the health system. And for me as a provider, it means that now women and girls know that they have the right to request an abortion, and without the risk of being rejected or criminalized. And this gives me the opportunity to take good care of all of them, and not just the ones that are lucky enough to have a good insurance or just to know me or know some of my colleagues that provide abortions. And not only to those that only had enough, not only care for those who had enough knowledge and who will, that knew that they had the right of an abortion under the previous law. So it also means that they will no longer be able to, the providers will no longer be able to lie to them, telling them that they are not within the exceptions. It means a vindication of women's moral agency to me. So many colleagues were concerned that abortions will increase and that women would be able to have abortions without a valid justification and just for any reason. So talking to all of those who I have provided abortions with during the past months, I have confirmed two basic and well-known facts. First, all of them would have had an abortion if the law had not changed anyway. So the law was not preventing abortions from happening, and they would still be happening even without that law, that new law. So most of them would have happened clandestinely, and many of them unsafe. So many of those patients that I've gotten to meet in the past months maybe wouldn't even be alive, or would be sick, or would have lost a lot of time and effort in getting an abortion. Second, the reasons for choosing an abortion are never different to the existence of a risk to their health and well-being, which was explicit in the grants that we had before. So they don't choose abortion now for lighter reasons, as most people fear that would happen. The difference is that they no longer depend on another person, in this case, a doctor, who is not going to assume the consequences of that unwanted motherhood, to validate the reasons and believe that the risk in fact exists. There were also major concerns about the 24-week limit. The stigma and misconceptions around abortion led them to imagine that now they would all deliberately go to have an abortion at 24 weeks, and that they would be forced to deliver live babies and let them die. So that's how wrong imaginaries are around abortion, especially after the first trimester. Evidence shows that the vast majority of abortions happen before 12 weeks, and only 1% happens after 20 weeks. And that was true before the new law, and it's true now with the new law that allows abortion up to 24 weeks. Statistics also show that there will always be the need for abortions above 20 weeks, mostly for reasons that are unpredictable before that time. And do we want our response to be for such, what do we want our response to be for such cases? It cannot be turning on backs and them. especially knowing that they are the most vulnerable ones. And very often the delays results from barriers that we impose and that society and health system in itself has imposed on them. Nor it is true that doctors will be forced to perform unethical procedures or procedures with which they do not agree. There are the right techniques described to earn the pregnancy safely and ethically at any gestational age. This is not something new because since before the new law, we had exceptions without a gestational age limit, as in many countries. In my country, there are reference centers where these techniques are practiced, and comprehensive and compassionate care is provided to women who require them. Just as no women have no frivolous reasons for having an abortion, no woman has ever sitted there to wait to turn 24 weeks or more to decide to go for an abortion. All of them were in extreme situations and in need for support and care, and not rejection and criminalization, as happens when we have ground gestational age limits. Finally, at the level of public health indicators, the possibility of us accessing safe abortion on request, that is when we remove grounds and gestational age limits, and as a service regulated within the health system and not the criminal code, and therefore under evidence-based protocols, allows all women who choose an abortion to receive comprehensive care that includes the offering of contraceptive counseling and immediate initiation of those contraceptive methods, detection of gender-based violence, for example, emotional accompaniment and appropriate follow-up after the abortion. All of these components are often excluded from care when abortion is clandestine, of course. All these elements allow women to prevent new unwanted pregnancies and new abortions, and let them know that they can count and trust on a health system that really cares about them and their families and their needs. When abortion is regulated as a health service and not as a crime, providers, we get the opportunity to help our community thrive. If we already know that decriminalization of abortion and regulation from a health ground has all these positive effects and that I just mentioned, and also averts preventable maternal deaths, then the opposite, and that is limiting or not having abortion access at all, prevents us from complying with the principles of beneficence and non-maleficence to which we are obligated by medical ethics. My only concern, actually, since you asked about concerns, is that if as a health system and providers, we fail to respond to this challenge of providing respectful and high quality and confidential services, or if we fail to provide as much access as possible under the current laws that we have in each of our countries, because there are many different systems, legal systems in different countries. And as you said, there's so many things that we can do from our position, and not just changing the laws, but providing access to abortion. Then women and girls in our countries will continue to resort to clandestine or unsafe abortions, and will be wasting a great opportunity to get closer to our vision at FIGO, for example, that women of the world achieve the highest possible standards of physical, mental, or reproductive sexual health and well-being throughout their lives. So you may learn more about our experience and the arguments that we produce and the mechanisms and advocates that we used from various backgrounds, including medicine, in an article that I'm going to link in the chat box, and also through a book that we have with all of the arguments that we use in front of the court that can also be applied to our daily exercise as doctors.
Great, thanks, Laura. I mean, I think you know, what you've done there is to really show in concrete terms what it is that a recommendation to remove grounds and remove gestational limits sort of means as a matter of law and policy. And I guess if I were to just put it a slightly different way to, you know, as a lawyer, how I think about it is when you have something like a grounds-based approach or gestational limits in the law, what you're doing is you're telling health workers when they may not provide a kind of health care. In other words, you're putting a limit on their capacity to provide health care with which they may be ethically aligned and which they may consider is appropriate and in a particular case, and which may be the preference of the woman who has presented before them. Whereas when you remove it from the law, you're taking away that prescription, you know, that statement that you may not provide care because of the law. And instead you're saying, well, what care you provide, when and how can be determined through no ordinary kind of medical evidence-based protocols and processes, including taking, of course, centering, of course, the preferences and values of the person who's seeking the care. In your answer there as well, you mentioned that you had been engaged before the courts, and I think that lets us transition very nicely to the conversation now that Antonella and Godfrey will have around processes of seeking to change the regulatory environment in which people avail of abortion care. So I'm going to hand over now to Antonella to start that part of the conversation.
Great. Thank you so much, Fiona. And thank you so much, Laura, for sharing those experiences. And Godfrey, I'll ask you to come in now because we've just heard about, you know, the setting in which Laura is working with recent reform, but where there were concerns around criminalization and also around expanding access, you know, what people were worried about when thinking about a grounds-based approach and also expanding gestational limits. And so I'm wondering, based on your experience in working with various groups and countries, are there particular strategies that you've seen that are used to mitigate the laws around criminalization grounds or gestational limits?
Okay. Well, I suppose the strategies employed by groups to get countries to comply with the standards and the recommendations would be informed by the different social and political and legal context. It may be important for groups to try and make gains where it is easiest to make a difference, or go for incremental gains while pursuing the long-term objectives. So in cases where the legal framework is less restrictive, there would still be room for improvement to enable quality access, access to quality care. So advocacy groups could, for instance, push for policies and protocols on telemedicine, abortion, where the services could be conveniently provided virtually or remotely. This has indeed proved critical, especially during the COVID-19 pandemic in countries such as South Africa. And similarly, where the legal framework permits, advocacy groups could ensure that quality abortion care is made more accessible through self-management, because that could remove certain barriers that women and girls face. So I am saying that even where the law is good or great, the recommendations in the guideline could still be important to further improve the quality of abortion care.
Would you say that there might be other avenues that advocates might be able to consider? So other ways to make change in terms of working with different groups, for example? Yeah,
so another legal strategy we're trying to pursue in Malawi is using the courts to interpret the current legal provisions. Because in some cases, access to safe abortion is problematic because of the ambiguities in the law or lack of clarity of the abortion laws or the provisions, or where the state is reluctant to comply with its own laws. So an example is like in Kenya, there's a recent case that was decided by the High Court on abortion. It was brought by the Reproductive Health Network, Kenya, and another partner, in which the court actually affirmed that abortion care is a fundamental right under the Kenyan constitution. And therefore the court was explaining how the Kenyan government should align its regulatory framework on abortion with the constitution. And in our instance, like in Malawi, abortion is criminalized, but not absolutely banned. And yet, women still have problems to access self-determination of pregnancy, because in Malawi, the law permits abortion if a pregnant woman's life is in danger because of the pregnancy. And yet, in practice, women with dangerous pregnancies cannot get an abortion. So as a strategy, advocacy groups may want to ensure that the country complies with the current law as an incremental step towards substantive reforms, towards like full decriminalization. So I think that's what I would say about that, Donella.
Great, thank you. And just quickly to comment, we had a question come in, or more of a comment, thinking about the links between criminalization or decriminalization and democratic countries. And what we're seeing is really that criminalization exists in most contexts, and that different countries are taking different approaches to sort of tackle this issue in various ways, some of which you've just elucidated. And so there's an opportunity really to think about expanding access, decriminalization in different settings. It doesn't always have to necessarily be aligned solely with a democratic scenario.
Yeah.
So you've just spoken about some strategies that NGOs or other advocacy groups use in their approach to law and policy reform. Can you expand a little bit more on how they might actually start working on reform in the country? Because it can often feel very daunting to think about taking on the penal code, for example.
Yes. So as I said, also countries have diverse regulatory frameworks and regimes on abortion, from those that are very restrictive, like Malawi, to those, and then to those that are more liberal, like South Africa, Zambia, and others. The basis for the advocacy is, of course, the same: to ensure that the provision of abortion care complies with human rights standards and is evidence-informed. However, the focus on the advocacy could differ according to what is obtaining in a particular legal environment. So let me give a few examples there. So as I said, for Malawi, the strategy would be that instead of going for a full decriminalization now, which is tricky and difficult, we have tried that, maybe we should go for clarifying the current law, so that the current law, so that women can access self-determination of pregnancy under the current law, which permits termination to pregnancy, but is restrictively interpreted by the policymakers. So the aim would be that while we are heading towards the full decriminalization, we should ensure that currently abortion is accessible to the fullest extent of the law as is now. So that's one of the strategies that we can do in countries like that are restrictive, like Malawi.
And are there other opportunities that can be explored, potentially thinking about things separate from decriminalization, or other mechanisms that can be used?
Yeah, because in certain settings, while the law permits, for instance, in Rwanda, you find that they have a different challenge. So in Rwanda, the Penal Code was reformed to comply with the protocol to the African Charter on Human and People's Rights, on the rights of women in Africa, the Maputo Protocol. And therefore, abortion is permitted on several grounds. However, a ministerial decree requires that abortion be provided only by medical officers with a medical degree. So this excludes other health providers who could actually competently provide the abortion services. So advocacy groups in Rwanda have been trying to get the government to vary or change the ministerial decree, so that then it enables health providers to to provide access to care. So you see, that's a different kind of challenge that they have, apart from the penal code being restrictive. And countries like Zambia and South Africa, for instance, they have got a liberal law on abortion, yet we still see cases of unsafe abortion there, because girls and women continue to face barriers to access the services in designated health institutions. So they still end up seeking abortion services elsewhere where it is unsafe. So here, then, the advocacy groups have got a different kind of challenge, and therefore they should use different strategies. Maybe it is about more about enhancing the implementation of policies on information and education on abortion services, or ensuring that the barriers such as third-party consent for requirements for minors are removed. So I think even in liberal settings like those, there will always be ways in which we can further, improve access to care.
Great, thank you so much. I mean, you mentioned the ministerial decree and you mentioned the challenges that it poses, but it also highlights that there are other tools that can be used outside of changing the penal code that can also be used in a positive way to sort of advance care. So in that current decree, it outlines who can provide, but you could also work towards a decree that expands those who can provide or include some of this other information. And you talked about enhancing policies too. So that could include, for example, a guideline, a national guideline, which is meant to be an implementation tool. And often it's the Ministry of Health who's charged with that responsibility to create that document so that providers and others are aware about how they should be interpreting the law. And so those are opportunities for change there. Great.
Yeah.
Okay.
Yeah.
So
again, just to add, I'm just thinking about what Fiona said there. In countries where it is the political climate is conducive, you can ask the government to put in place a moratorium. You just made, it happened when on the issue of criminalization of LGBTIQ in Malawi. So maybe if governments can accept to have a moratorium, that's also another maybe strategy to use.
Great, thank you.
Yeah, go ahead. I just wanted to highlight that.
Yeah, no, it's good. And also, I'm just wondering, I mean, it's not just about changing the law or policy, right? I mean, it's also about changing how we think about abortion and how we work on this issue. And so I'm just wondering, we've talked a lot today already about thinking about abortion as healthcare and regulating it as healthcare. And so, can you comment at all about how maybe we can work with stakeholders in the community, such as community leaders or religious leaders, or even members of parliament, to think about how we can think about abortion differently?
Yes, so that has also been an area that is critical in our work. Like in Malawi, we have been trying to work with the members of parliament and the community leaders, including religious leaders and traditional leaders. Well, the silence about around abortion is really an effect of stigma and patriarchal gender norms and stereotypes, oftentimes reinforced by religion and cultural beliefs. So what stigma does also, it contributes to political marginalization, because people who need an abortion are unable to express their needs or defend their rights for the services they need. So it is really important to engage community leaders to work towards some common grounds of interest to protect the health and of girls and women. I am sure that our leaders have an interest in the health of girls and women. However, it is also key to empower girls and women themselves. When a critical mass of the grassroots can demand the change they need, no religious or traditional leader or parliamentarian would stand in the way. We have seen that, like in Argentina and in Ireland, amongst others, where it was really the movement of girls, women, and of course, with the support of others, that changed things. Let me just say this, this political marginalization of the grassroots is one of the enduring effects of colonialism. People believe that colonial abortion law is impossible to change and that it is aligned to religion and cultural beliefs. I had that experience when we engaged parliamentarians in Malawi. They told me in my face that the English law of 1929 was better law than the liberal termination of pregnancy bill we wanted them to consider taking up. Yet, democracy means the power of the people to change their circumstances, including laws that do not serve their interests. The evidence is there. No matter the legal or religious environment, everywhere girls and women who want an abortion will try to get one. That's why we have so many cases of unsafe abortion where it is legally restricted, or where women and girls face barriers to, to access. I would not be surprised, for instance, if we see an increase of unsafe abortions in the USA because of the recent Supreme Court decision overturning Roe versus Wade. I do not believe women want the injury or death. They would choose a safe abortion if this was made available to them. So advocates should facilitate empowering people to transform the law, policy, or practice using political means such as parliamentary processes. We have seen that in cases like Northern Ireland, where legislation was changed to enable access to safe abortion, or engaging the judiciary to facilitate law reforms and even hospital practices. For instance, the 2021 Mexico Supreme Court ruled that criminalizing abortion was unconstitutional. And then the example I gave also earlier about Kenya. So advocates should motivate the grassroots to seek the change they need and to pursue the necessary means to achieve this change. So that's what I can say about that.
Great, thank you so much. All right, before we open up for Q&A, I don't know, Fiona, did you want to come in with any final thoughts here?
Sure. I mean, I think what both Laura and Godfrey have told us really reinforces a couple of things that also, came through in the evidence, and that I think are important, perhaps are useful for people to think about as they begin to think about how they might implement the recommendations or seek to implement the recommendations in the guideline. And for me, I think the first of those things that they surfaced is the importance, as Godfrey just put it, of ensuring that you secure access to abortion to the maximum extent permitted by the existing law. So in many settings, we see either that the existing law is quite restrictively interpreted, as Laura was also talking about, or that there are cases of what we might call over-compliance. So we put in place kind of practical protocols or practices that are not actually required by the law at all. But they become part of the sort of system by which abortion is provided. So, for example, Laura was talking earlier about her professors saying they were ethically required to report people they suspected of having had unlawful abortions, even though maybe the law did not actually require them to do that. Or, asking people more questions or involving parents or something for adolescents, even if the law does not say you have to do it. So we can identify, I think, or think about identifying places where already there are practices that are not required by law, but which in practice exacerbate the limitations of the law and seek to address those. And they don't require, legal change, which is this longer process, as Godfrey was just saying. And I was also really struck by that very important point.
Sorry, could I just come in for 1 second, Fiona?
Please.
Just to add on that, because it reminds me, in thinking about those kinds of action points, we could really think about, the clarifications that could be provided in the guidance, thinking about the biases that might be based on personal preferences or opinions, and sort of structuring systems in a way that facilitates access to individuals who are not going to impose those judgments. I mean, we don't want people who don't want to take care of women taking care of women. That we want people who are interested in delivering quality care, non-judgmental care without stigma, delivering that care. And also thinking about this piece about funding. I mean, Laura had mentioned, when funding was provided, it improved access to quality care. And so that, I think, is another piece there. Sorry, I was just struck by that. Okay, keep going.
No, that's great. The second thing in particular that Godfrey said that I wanted to pick up on, because I think it's so important, is this sense, which in your context you identified as lodged in the colonial legacy of the laws, and that was the same in some ways in Ireland, where I'm from as well, but you see it in other places as well, that the basic structure of abortion law is kind of immutable or that we can't change the basic structure because it has existed for so long, or what have you. And the basic structure, of course, is to start with criminalization. And as we said earlier, it is that starting point that tends to produce these other legal interventions that operate as barriers. And so one of the kind of challenges is to seek through advocacy and practice, as both of you were describing, to move ourselves away from assuming that starting point, assuming that the starting point is that abortion is a crime, and that what we're trying to do is ascertain when it may be permitted or when it may be allowed, rather than seeing it as healthcare. And that, I think, can really feed in to those multi-level strategies that Godfrey was talking about, seeing opportunities in activism, in engagement with these kind of policy documents that don't require, a new piece of legislation or a court case or whatever to change. And also, of course, in identifying which kind of strategy might work best in any particular context. And that, will always depend on the context in which people are working. I think Laura wants to come in on that point, but yeah.
Yeah, Fiona, you made me think of the different contexts in Latin America, because there's been different strategies in different countries. And for example, the risk reduction strategy in Uruguay and Argentina, where abortion was partially criminalized at that time, was very successful, because it is a great example of how, even though abortion was a crime in their penal code, doctors were aware that information was a fundamental right, and they could give information to their patients in order for them not to resort to unsafe abortion. They could tell them how to use medication, and this actually opened the door to a more liberal law in those countries. And it started off as a practice of service delivery, not as a justice or criminal law change. Also in Colombia, I think that normalization of the health exception of provision of abortion because of unwanted pregnancy under the ground of the health exception was also so important to demonstrate the benefits of providing access or wider access to abortion. And one of the resources that I think was very important as providers was to intervene in the production of protocols, of clinical protocols, because the protocols did not only have the technical aspect of abortion, but also the interpretation of the law. And this is not just for information, but also for validation, and to counter all of that fear that doctors may have to interpret widely the health exception. So I think those are two examples of very successful experience protocols and risk reduction strategies in which we can apply these recommendations from the OMS.
I just wanted to follow up on that, Laura, because when you say you use the harm reduction, it opened the doors. So that's what I've been talking about with fellow advocates. Okay, we want a full decriminalization here, but there could be ways of opening that door, just expand it a bit wider. If we can get people to appreciate that abortion is accessible even under the current law, it might even empower the women themselves to understand that, this can be accessible, and then lead towards, that full decriminalization. Yeah.
Great. And I mean, I think one other thing just to note that both, has come out in both of your responses is that it's not just about law and policy. It's not just about guidelines. It's not just about, tackling these issues, but it's also about dealing with the stigma and also about potentially the harmful gender stereotypes, seeing women as primarily childbearers and mothers, and thinking about other ways to be inclusive in our strategies. All right, so on that note, I think we can open up now for a Q&A session. So as mentioned before, we would ask all to post your questions in the Q&A section, and we will try and answer them as they come through, and also potentially consolidate if there are many. So at the moment, I don't see any questions, but we'll see. We'll give people some time to type in the chat.
Just while we're waiting for the question, I'll just pick up on that comment that Getachew Bekele put in the Q&A, because I think it's an important point where they say that decriminalization is a necessary but not a sufficient condition, and I think that that's absolutely right. So, you know, the 7 recommendations that are contained in the guideline are of course connected, as Antonella said earlier, but I think it's probably fair to think about the recommendation for full decriminalization as being, you know, the absolute foundation for the ability to create a law and policy framework for abortion that is rights respecting and forms part of an enabling environment. Because as we've said repeatedly today, as long as let's say the starting principle is the criminal law, then the whole structure is designed as a structure of criminal law rather than a structure of healthcare provision or service provision or evidence-based healthcare. And so the absolutely mere decriminalization would not change things, would not be sufficient to ensure quality abortion care, but it's extremely difficult to envisage how you could have maximal quality abortion care without decriminalization.
And just 2 quick points on that as well. And we've been talking a long time, even before this guideline, about the chilling effect that exists around the criminal law. And so we continue to see that. But also, this speaks to the fact that, again, it's not just about law and policy reform. It's also about thinking about the other elements of the enabling environment that must exist to ensure access to quality abortion care. So access to information, access to services, access to individuals who are well trained, or for those who are self-managing, to the information they need to do so, or the medicines that they need to do so. So thinking about all of those pieces as well, as so we're really creating that holistic environment for the provision of this service. Godfrey, did you want to say something? I came in when I saw you wanted to say something. Sorry. No, come. It's okay.
But I could. I may preempt someone else's question, but I think it is still something I can say because we've been talking about that with some colleagues. You see, certain countries may have a better law than even what is recommended by, say, the Maputo Protocol, because the Maputo Protocol suggests a grounded approach. So the question is, well, we comply with the Maputo Protocol and that's a human right. So the response to that is, normally we look at human rights as setting the minimum standards. So it does not restrict states from going beyond the minimum standard. So what the Maputo Protocol is saying is that as a minimum, this is what you must do. It is not like saying that this is the only thing you can do. No. So states, for instance, like South Africa, already provides more than is required by the Maputo Protocol. So I'm just putting it out there that the WHO is recommending, set this guideline is evidence informed, but states cannot then invoke human rights to limit themselves to the minimum. No, because this is evidence informed of the way that, about how things can work better. So I think states should, try to make things work as best as they can in their countries. Yeah.
Go ahead, Laura.
Yeah, Laura.
Yeah, and thinking about that from the medical point of view, we as doctors never aim for the minimum benefit. We always aim for the greatest benefit. So why should this be different? I mean, women and girls deserve a lot more than the minimum standards of care. And this is what decriminalization is about.
Yeah, and if I can, it's a great point. If I can just come in on that precise point that Godfrey made, I mean, one of the things that we found in the evidence that underpinned the recommendation about grounds was that grounds-based approaches, in other words, a law that specified grounds, often did not actually work to give access to abortion for everybody who qualified or who would fit that ground. For all the reasons we've already discussed today, you know, like maybe the grounds are themselves too limited, or interpretation is limited, or the shadow of criminalization means that health providers are conservative or cautious or hesitant in how they apply that. So even if one were to say, for example, the Maputo Protocol requires that we make abortion available in the following situations, the evidence suggests that the way that a grounds-based law is not an effective way of making abortion available in those situations. And of course, if you had a law that permitted abortion on request, it would also make abortion available in all those situations. And the last point on that is just to recall also that under the International Covenant on Civil and Political Rights, the Human Rights Committee has said that states must ensure abortion is available in all situations of a risk to the risk to the life or health of the pregnant person, or importantly, where continuation of pregnancy would cause substantial pain or suffering to the pregnant woman or girl, including but not limited to rape, incest, and situations of fetal malformation or anomaly. So that, if you want to think about that as a ground where continuation of pregnancy would cause substantial pain and suffering, you see there that's actually very broad and is probably not satisfied by the ways in which ground-based laws are currently generally designed. So I just want to reinforce and agree with what Godfrey said there, not only that you can go beyond it, but also that ground-based laws may themselves not be sufficient to satisfy something like the Maputo Protocol. That's it, Antonella, for me. Sorry.
Yeah, no, it also has me thinking, I mean, both of these comments, as a provider, I mean, we don't typically look to the penal code to guide us in medicine, except in the case of abortion. And also thinking about rights, I mean, we're not often trained in thinking about the aspect of human rights, and so how that all works together. And so there's opportunities also to think about how we can do better in empowering individuals, all sorts of individuals, to think about the human rights aspects, but also in thinking about locating care where it's supposed to be located, which is not traditionally in the penal code, and getting us sort of, again, used to the idea that it's not the norm for everything else. There is a question in the Q&A that I just want to quickly address, which is about whether or not promoting self-managed abortion can be a good strategy in restrictive regulatory contexts. And so we would just say that, you know, the abortion care guideline does include recommendations on self-management, and self-management is one approach in terms of thinking about access to care. And so we would want to encourage that all options be available to individuals, and that the system is set up in a way and that an enabling environment exists so that individuals can access care in the way in which they want it and the way in which they're seeking it. And so that might be self-management for some, but it might also not be self-management. And we also know that self-management might also not be medically appropriate for some individuals. And so there is that consideration as well. So again, the idea is thinking about what is the onus on the state to ensure that an enabling environment exists at minimum for what the law says that it's supposed to be doing right now, and then again using that as the minimum and what can be built upon that. I don't know if there are any additional comments on that from the panel or from Fiona. Okay, great. Any other questions to come in here? We're getting close to the end of our discussion here. So I don't see any open questions at the moment. Fiona, did you have any? Oh, go ahead, Laura.
Yeah, actually, Antonella, I would like to go back on that self-management question, because yes, all of the options should be available. And yes, sometimes I feel that governments and health systems have taken their look away from abortion because women have resolved the issue where there are restrictive laws. But I do think that self-managed abortion, starting from the communities and women, have provided us with enough evidence showing that first, it is safe, and second, there's a lot of benefits from safe abortion with enough information and self-managed abortion. And they have taught us why decriminalization is important, because they recreate what on-request abortion would look like. And it really looks a lot better than unsafe abortion in our societies. So yes, I think supporting self-managed abortion with enough information and with evidence-based protocols is important, and is a good strategy for demonstrating why abortion on request is good for health systems and for communities.
Great. Any additional thoughts here? Okay. Fiona, any final thoughts before I share? Okay, so I'm going to go back to sharing my screen. If you give me 1 second. All right, so we thank everyone for joining us today. But before we close, I want to highlight again, for those who may have missed yesterday's presentation, some important information relating both to the guideline and other resources that are available. And so we have the guideline that is available in PDF format, in an interactive digital format, as well as the executive summary, which includes all of the recommendations consolidated. And these pieces of information are also available in multiple languages. And then I just wanted to make you aware of some derivative products or upcoming products that we have coming out. And so we're anticipating releasing an evidence brief around the law and policy recommendations, as well as operational guidance, both on the implementation of the law and policy recommendations, but also other recommendations as well. So for example, we have an existing clinical practice handbook for our abortion care, for our previous abortion guideline, and we will be updating that to match our abortion care guideline, as well as additional materials such as pocket charts and cards and decision support tools that are in development. And then we have other resources that are available to you on abortion, which can be found on our abortion topic page at WHO's website. We also have our global abortion policies database, which allows you to look at individual country contexts, as well as do country and regional comparisons related to the laws and policies of all the UN member states. We have social media tiles and fact sheets and articles. And of course, we've now completed 2 webinars, and we invite all to participate tomorrow, where we will do our deep dive into mandatory waiting periods, third-party authorization, provider restrictions, and conscientious objection. We will be joined by 2 different and distinguished panelists there. And if you've not registered and you would still like to do so, please see the link in the chat now. And then, as mentioned yesterday, and then at the start of this webinar, the webinars are recorded and will be available for viewing in a few days. And we will also be sharing the presentation in PDF format, as well as the links to the recordings. We also invite you to stay tuned for future webinars. And if you're not already a member, please join the IBP platform. It's a digital space where you can get updates on other upcoming sexual and reproductive health and rights webinars and events. You can receive news about WHO guidelines and other tools, and interact and exchange knowledge with people around the world who share an interest in a variety of SRHR topics. Signing up is free of charge, and you just simply go to the ibpnetwork.org site to do so. Being a member allows you to join a range of communities of practice, including one on comprehensive abortion care. So thank you very much for your attention today. Thank you very much to our esteemed panelists and for sharing your experiences and helping us tackle all of these issues and help us think about how we might operationalize some of these recommendations in various contexts. And thank you to Fiona for your participation and your assistance as well. And we do hope that you'll join us tomorrow for our final webinar in the series. And of course, keep an eye out for additional webinars to come. Thank you.